that would allow people the flexibility to choose what type of insurance they want if they're starting to work and it financially doesn't make sense to for a single individual. It's not much money. You have to have ways for people who are making slightly more than that to feel confident that they're protected.
Well, I think the American people want to know, just from your nomination and from this process that we're going to go through, what is it that Republicans believe? If they're saying next year, which I think the president is saying, we're going to cut off all of those silver plan subsidies, I'm saying I at least want to hear from you whether you believe that bundling those people up into a virtual bundle, I think is what you called it in my office, and allowing them to have that market power is an idea that you agree with.
Senator Caldwell, I look forward to confirm with this committee to researching that in detail. It's a promising enough idea that if you'll take me into your office again, I would love to visit you with it.
Okay, well, definitely my vote will be predicated on this. So I can't wait till after you're confirmed. I need you to think about this because, look, you're coming with the ability to be an advocate here. So we want to know what you're going to be an advocate for. And
what's up, everyone? You are watching Your Freedom Rising. We are watching the Senate hearing of Dr. Oz.
Million people now in the state of Washington. It is basically the number of people in my state who are getting maternal care from this is an exorbitant. The number of kids getting care from this, is high. 47% of kids in my state receive insurance from Medicaid. And we have population centers of our entire state that are well above 50% Medicaid, Medicare populations. So how do you deliver health care to Central Washington when it's that level? So we want to know whether you're going to commit to concepts. If you don't like some aspects of the Affordable Care Act, you should say which ones you don't like. Thank you very much. But I hope that you will learn that the Affordable Care expansion of Medicaid work and virtual bundles that give consumers more clout also work. Thank you.
Thank you. Senator Lankford.
Chairman, thank you. Dr. Oz, thanks for going through the process on this. You've been very outspoken for years for the health of Americans and for Americans taking better care of themselves and for us finding out how to be able to do that better as a nation.
Thank you,
I
sir.
appreciate the work that you've done on this. You and I have visited already on several of these issues, but I want to be able to probe a little bit farther. The pharmacy benefit manager issue has been one this committee has taken up in a bipartisan way. We spent a significant amount of time last year as a committee. We passed overwhelmingly a pharmacy benefit manager bill out of this committee. We tried to be able to get it actually to the floor. Senator Schumer didn't ever bring it to the floor last session, then tried to get crammed into a last-minute bill on the end of the floor and didn't fit. With all that, the problems still remain on this. Some of them CMS can take care of. Some of them this committee has to be able to take care of as well, as we've got to be able to finish that work that has been nonpartisan work here to be able to get done. 450 independent pharmacies closed last year, more than one a day. Most of those pharmacies, if you went and talked to them, they would say the breaking point was what pharmacy benefit managers are doing. That is mostly rural health care, and the access to that pharmacist in those rural areas all over the country is lost. And people are gonna have to mail it in because a PBM makes more money to be able to do that. That's a major problem. There has been a rule out there for CMS, the non-interference rule, that has created a challenge for CMS to be able to engage. What is it that you feel like you're gonna need as far as authority to be able to engage on the issue of PBMs, and thoughts that you may have on that?
Senator Lankford, you had remarkable and deep insights into PBMs, and I appreciate taking time to learn about them because although they do provide an important service, taking the medications from the pharmaceutical company that's created the product and putting it into the pharmacy system, or as you point out, mailing it directly to patients, they also create a pricing spread. And that's where some of the problems occur. The lack of transparency into what goes on when that pill leaves the pharmaceutical company and ends up in your home is where a lot of the money's made. And so I think if we can bring or insist on complete and radical transparency in what's going on with our drug markets, it would help CMS tremendously because it would allow us to understand, for example, is there spread pricing going on where those pharmacies that are going out of business are paid a much lower number than people are charged for the medications that they're getting. And then paid for by the U.S. government or other sources. Those are a problem. It's also an issue, as you know, if the actual rebates that are given, which is part and parcel of the PBM system, an archaic but widely used approach, if those rebates are actually fully rebating the monies that's being saved by the negotiations done by the PBMs. And I don't think anyone in this room, and hopefully no one watching, would ever think of doing a transaction where they didn't have a little bit of insight into what everyone else in the party was involved in how much money they were going to make as a result of the negotiated result. And I believe, in order to protect the American people, and President Trump has been very clear on this, want to reduce the cost of medications to our government and to the American people, the copay. That's not happening right now, and we can do better. And the PBMs are one way of affecting that change.
Yeah, we certainly can. The rural healthcare and the provision of that is a challenge. It is a challenge all over the country, and there are occasionally folks in Washington, D.C. or in urban areas that don't think as much about rural America. Those of us that live in rural America and those families that we know firsthand know they also have heart attacks, they have babies, they have lives and struggles and emergency situations. They need access to health care. They also need someone to be able to talk to say, hey, I've got a question about drugs and about interactions and what this looks like. That's their local independent pharmacist often on that. One of the areas the PBMs has been particularly bad on is this issue about tiering, where brand name drugs will come out, they'll give a rebate if the generic that's going to compete against them will go in the branded tier. That drives up the cost for American taxpayers. It drives up the cost for the federal government. It is a big issue on that. The latest studies that came out said more than half of the generic drugs are actually on the wrong tier. That's an issue that we need to be able to address legislatively, but it's also so I'll look forward to that conversation in the days ahead. Another issue, we have a shortage of nurses around the country. President Biden's CMS, long-term care facilities, nursing homes, other facilities, that they have to have 24-hour care for a RN that's in that location. Now, that sounds like a great idea unless you're in a town of 5,000 people and there's just not another nurse that's available to be able to do that. So the real result of that is it's going to close rural nursing homes all over the country on this. This is an action that the Biden administration CMS took directly on this. This will be an issue that you'll have to be able to address soon on that. I would ask only that you come back and review that, because we'd like to keep rural nursing homes and long-term care facilities open and available for those families, not have them closing and just tell them in rural America, drive 200 miles with your family to get access to care.
Senator Lankford, thank you for raising that. It's an issue that I have spoken about with community groups quite a bit in preparation for this meeting. If confirmed, I pledge to come back to you with my thoughts. Senator Wyden brought up the exact same issue
I would ask
from the other
that you come back and
perspective. So
review
I
that,
appreciate
because
the arguments that are being waged here. They're thoughtful ones that deserve more attention, and it'll be one of the earlier things I focus on.
Thank you. Thank you, Mr. Chairman.
Thank you. Senator Cassidy.
Dr. Oz, I'll overlook the fact that behind you are some of my former staff members who have been stolen by the department from my department. So
They're well trained, sir.
I'll overlook that. Prior authorization, you're a provider. You know how sometimes care delayed is care denied. Speaking to a surgeon in Florida who said if he had gotten the prior auth like that, the surgery would have been less expensive, the rehab shorter, the patient's outcome better. Your thoughts, you're a provider, what do we do about prior auth issues in the Medicare Advantage program?
Senator Cassidy, thanks for your years of service to your patients and to the clinics that you've helped run and create, as well as the service in the Senate. And I've enjoyed our conversations, numerous ones, about broad health care policy. This issue of pre-authorization is a pox on the system. We spend 12% of the healthcare budget on administrative costs. Pre-authorization is misused in some settings. There needs to be a mechanism to confirm that procedures are worthwhile, but I'll offer some ideas on how this might work. And if confirmed, I'd love to push some of these ideas and share them with other members of the committee. There are about 15,000 procedures that could have pre-authorization. They represent most of the things that are done. They not just insurance companies today use pre-authorization for about 5,500 of those procedures. But interestingly, not all insurance companies focus on the same things. And even within the idea that's the procedure that's being pre-authorized, the criteria for accepting it are also all over the place. So it's very difficult to automate that. And so it tends to be misused because it stalls the process, as your physician colleague in Florida pointed out, makes it more expensive, and we're spending money, wasting money, trying to do a process that should be automated. I would argue we could limit the number of pre-authorized procedures to 1,000. Be very clear, if you're gonna have a knee replacement and you can bend your knee more than 120 degrees, you don't get the knee replacement, or whatever number you wanna put in there. And then if we know those numbers ahead of time, like a credit card appropriate, credit card approval doesn't take you 3 months. You know immediately whether the transaction's approved or not. We will be able to do something similar so that pre-authorization can happen rapidly. And
Let me ask you this then, because my docs will be so frustrated because they have previously gone through step therapy with the patient to get them, okay, this medicine didn't work, this medicine didn't work, this one didn't work, now this one finally does. Yeah. They change plans and they're being asked to go through step therapy once more, therefore giving the patient a valley of lack of response until they get to where they've already know they should be. Thoughts?
Senator Cassidy, that is one of the most frequent complaints I hear from physicians. Patients see it on the other side, which is I can't get the treatment. I'm in agony, I'm in pain. I really know what works for me, but no one will give it to me, even though I have insurance. Like, I'm part of Medicaid, I'm a beneficiary. I should be allowed to get access to this medication, which I'm told is in the plan, and yet it gets slowed down. This is a place where it's a matter of competency. This is not a Republican-Democrat issue. If we can do the job that's been assigned to us at CMS in a competent fashion and revisit some of the assumptions we've taken for granted for decades, that's being a good one, and use technology that today could help us. Because we have AI support tools, navigation systems that could pretty quickly adjudicate whether you should have to wait even a day to get the medication that will get you out of pain, or even a week for the procedure that you should be allowed to have. It'll take a lot of the angst out of the system for the American people. I mean, the healthcare executive.
I'm with you on that. I've got limited time. Let me ask you one more thing, or a couple more things, hopefully. There are local determinant decisions, a regional determinant decision, and Medicare is supposed to cover something unless it is said not to be covered. I'm told that there are MA plans which are reversing that and saying they will only cover something if there is. Now, as we look at the trust fund going insolvent and our budget deficit expanding, is this a place you would look, and if so, how would you look in terms of getting better value for the dollar?
So the MedPAC assessments have revealed what you just shared, that we're actually apparently paying more for Medicare Advantage than we're paying. That's wrong. And I think we have numerous tools, but part of this is just recognizing there's a new sheriff in town. We actually have to go after places and areas where we're not managing the American people's money well. And if we can do that effectively, and both of us, I think, agree that there are opportunities to do that that are massive in scope, but they're also important emotionally for the program. You want people to have confidence in the program. The employees administering, the career employees administering Medicare, and the beneficiaries should all feel the system's working for them.
On the upcoding, we're out of time. Thank you, Mr. Chair. Senator Merkley and I have a bill, the No Upcode Act, that actually achieves that. So I think you're going to be confirmed, and we'll discuss that with you at a later date. Thank you.
Thank you. Senator Hassan.
Well, thanks, Mr. Chair, and welcome, Dr. Oz. Congratulations to you and your family on your nomination. First question that I'm asking of every nominee for this administration: if directed by the president to take action that would break the law, would you follow the law or follow the president's directive?
The president would never do that.
That's absurd. It's a disappointing answer. Now, the Medicaid program covers over 70 million Americans, and the Congressional Budget Office has now confirmed that the Republican budget plan would require taking away Medicaid coverage for millions of people. In New Hampshire, the Republican budget could take away health insurance from as many as 30,000 children. Do you support the Republican budget plan that terminates the health coverage of millions of Americans, including as many as 30,000 children in my state?
Senator Hazard, I've not seen the details of a House bill that says that. I look forward to examining it with great care if confirmed by this
So let
committee.
me ask it another way. How many children losing health insurance would be acceptable to you?
I don't want children losing health insurance.
Well, then you're going to need to reject the Republican budget plan. You and I did talk about maternal health crises. Medicaid covers 40% of births in America, 50% of all rural births. So will you commit to preventing any cuts to Medicaid that will deny moms health care coverage?
I'm very focused on maternal health care. It's one of the metrics that our nation, I think, should be judging itself on. We do have to make investments, I believe, in maternal care in order to provide better sources.
So will you make sure that there are no cuts in the Republican budget plan that would deny coverage to pregnant moms and moms postpartum?
Senator Hassan, I have to be more knowledgeable about
Yeah.
what's happening within CMS. I don't have
Asking
any
blanket
idea where the
statements.
money's currently
Let me
being
be
spent.
really clear. The Medicaid cuts are draconian
Are
in the
crazy.
Republican plan. The CBO has said that it will lead to significant cuts, and
This
the cuts will
woman
likely lead
has
to
lost it.
10 states losing their Medicaid expansion coverage. So let's move on to another issue. Last week, the Trump administration put out a list of federal offices to close, including the only office in the North Country of New Hampshire where seniors can enroll in Social Security benefits and Medicare in person. If confirmed, will you work to ensure that seniors can continue to enroll in Social Security and Medicare benefits in person in Littleton, New Hampshire?
I don't know about why there was a decision to remove this center in northern New Hampshire, but I do believe seniors will be better treated if they can see someone in person.
Right, so do you think they'll be better or worse off in rural areas of my state if they have to drive 100 miles to the next closest office in New Hampshire? For the record today, can you confirm that you no longer believe
These
that
people
green
sell
coffee
drugs
extract
to
is a
everyone.
miracle weight loss drug?
Without remorse.
I never said that medication was a miracle weight loss drug. but
Come
I
on.
am very-
Can you confirm that this was fraudulently marketed and green coffee extract is not a miracle weight loss
Green
drug?
coffee?
Yes or no?
Yes.
Okay, so let's go on to, you promoted a supplement called Raspberry Ketones, claiming that it is, quote, a #1 miracle in a bottle to burn your fat. That's your quote. Will you confirm for the record today that you no longer believe raspberry ketones to be a, quote, miracle in a bottle?
Fair enough.
There are many things I said on the show. I take great pride in the research we did at the time to identify which of these worked and which ones didn't. Many of them are still being researched, like the green coffee bean extract you just mentioned.
So how much were you paid to promote these supplements? Promotion of unproven snake oil remedies
He
to
did.
millions of
He
your
admitted
viewers, and that's
one of
really
them.
concerning. Thank you, Mr. Chairman.
This
Senator
lady's
Whitehouse.
inability to speak
Oz,
without
over here.
aggression is concerning.
As we spoke about when you visited, I want to talk about some Rhode Island issues, because Rhode Island has a very fundamental issue, which is that between 2018 and 2023, which is the most recent years for which we have data, Rhode Island hospitals
This dude's
were
serious.
paid less than nearby Massachusetts and Connecticut hospitals by a margin of over 20%. The margin of underpayment for Rhode Island hospitals compared to hospitals across the border ranged from between 20% and 28%. As a doctor, I think you pretty well understand that if you've got, we can't fix that, the way to do that is to get out of fee-for-service and to a value-based program. We just heard that the AHEAD program is going to continue forward. I'm delighted about that. You and I are going to be in touch about making sure that Rhode Island's AHEAD program competes fairly with Connecticut's AHEAD program, because they work off a cost basis. And our cost basis has been suppressed by 20 to 28%
Sure.
lower
Let's go ahead and do
payments.
that.
You can't pay your nurses, you can't pay your cleaning crews, you can't pay your phlebotomists the same amount when your revenues are 26, 28% below your competition. And let me just add to
Yeah,
this
let's
by
go ahead and do
pointing
that.
out,
How about we
you know
prosecute
this area, right? You practiced in Boston.
hospitals
I went to school in Boston, but I practiced in New York.
that kill
Okay.
people during
So from
COVID?
going to school in Boston, you probably know that Rhode Island's hospital complex in Providence includes Rhode Island Hospital, which is the only level 1 trauma center in southeastern New England, the only level 1 pediatric trauma center in southeastern New England, the only verified burn center in Rhode Island, an academic medical center, a teaching hospital, has a pulmonary hypertension center, and obstetrics and a NICU are at women and infants. It is a node of connected buildings that provides extremely high-level care. If a president is in Martha's Vineyard and gets hurt, Rhode Island Hospital Trauma Center is where they're taken. They fly right over St. Anne's Hospital in Fall River to get to our hospital in Rhode Island
Interesting.
because we made the investment in level 1 trauma care. St. Anne's Hospital that they flew over would be paid 20+% more for the same services while delivering none of those options. So I'm going to be on you like a ferret to get this fixed. It is totally unfair. Bacchus Hospital is probably a 25-minute drive into Connecticut from Westerly Hospital in Rhode Island. It's probably a 25-minute ride from our trio of world-class hospitals, Rhode Island, Hasbro Pediatric and Women and Infants, to St. Anne's Hospital, just out 195. And for the same service, we get paid 20 to 28% less than in those hospitals. I am so sick of CMS right now, it just
We could
makes
tell.
me
Yeah.
infuriated.
Angry.
For years, CMS has sat
We could
idly
tell.
by, looked at that payment differential and said, oh, what a pity, too bad, we're not going to do anything about it. And we tried to fix it through the AHEAD program. Oh, well, maybe, but I don't think so. So
I feel it
we
though.
really need to get this fixed.
The
It
workforce is
wrong,
frustrating.
and it is really
really can be.
dislocating healthcare
When
in
stuff
Rhode
doesn't
Island.
get done.
We have doctors moving over the border to take advantage of better payments. We have a fight for staff when we have to compete with other hospitals within the same commuting range that get better payments. So I have 10 seconds left. I'll leave it at that. You heard a lot from me when you came to sit with me. You heard a lot from me today.
Yeah.
I'm going nowhere on this. In the years I've been fighting it, not once has any person at CMS ever been able to provide any excuse or any justification for it. None. They don't even try to justify it. They just don't give a red hot damn about this incredible unfairness that is dislocating and warping our healthcare system. So if you'd like to respond briefly, please do. I suspect I'll hear you look forward to working with me on it.
I don't know, man. Oh no.
Well, I did a little homework
Anger
after the office
management?
visit, the thrashing that I experienced.
But thrashing CMS, not you. You're not responsible for this yet.
Yet. It does seem to require a statutory solution. However, the AHEAD program is a promising potential opportunity. I don't know enough about how the reimbursement would be altered, but I did want to point out that I went back and looked at the numbers that you shared with me. And it's interesting that how they were calculated. Again, it was driven by a congressional formula, but Senator Sanders, for example, he's paid 25% less than you.
Wow.
So if you think Rhode Island has it bad, Vermont's really that way below the average. So
I very much enjoy meeting with you, Dr. Oz, and having a really great discussion, talking about the innovation and the experience you bring to this job is almost unprecedented. You're exactly the right person at the right time to take over this in ensuring that our federal health care programs are not providing abortions on the taxpayer's dime.
Yeah, please.
He spearheaded efforts to ensure that seniors could have access to innovative medical devices through addressing this limitation that the Biden administration placed, or create a coverage pathway for innovative devices with existing strong clinical data.
Senator, yes, I think we lose a major, and eventually received CE mark. We had a regulatory apparatus that was not transparent. I believe we can do better. And to your point, I believe we can do better. And to your point,
To pack an elk out when you quarter it, but it's an important tool in the overall tool chest to help us provide better access. What are your thoughts on ways we could ensure that health